So, all right. When I do like my bio, I did general surgery, critical care at the trauma center in Baltimore. Did a fellowship at Harvard Medical School. Um, Wound up in vascular access. Became the president of the Association for Vascular Access, and I've kind of traveled around the world lecturing on this very topic. Been to some cool places: Russia, Turkey, Saudi Arabia a couple times, Brazil, Italy, England, Hong Kong. So it's been a good ride. So what I did is I walked around the hospital with a video camera, recording procedures, and I even captured complications as they were occurring. And I'm the only one that I've ever seen that has that. So that's my background.
Awesome.
Yeah, yeah.
Nice.
I don't get to
Let
do
me
that
let me just
presentation.
yeah. So hey everybody, good afternoon. There's you probably saw the agenda. Maybe only one thing from my side. Make sure that health streams we're getting them complete. I think the deadlines are in the beginning of January, so you have some time still. The two main things for today. Dr. Jack De Leon, late Don, is going to be talking about line placements, and I think the focus was going to be a little bit on BioPatch also, and how they to decrease CLABSI and how we should be using the BioPatch, since we brought them back to Fairfax instead of the CHG impregnated gel. And then after that, Rory from Sedline is going to talk a little bit about pearls and any questions we have about Sedline usage, which I'm sure some of us do. Jack, why don't you get started with the CLABSI and BioPatch discussion first?
Thank you very much. So this is my title. These are the companies that I speak with, so full disclosure. They asked me to talk about skin prep a little bit. Skin prep is basically a 30-second back and forth vigorous friction prep unless the area is moist, and then you would extend that out to 2 minutes, right? That orange is sodium hypochlorite, which is a stain for chlorhexidine. And what I like with my chlorhexidine is I want it wrapped around the catheter where the catheter damages the natural barrier to infection, namely the skin. There are other products that have a different configuration where the chlorhexidine is more out in the periphery. And I don't really care if it's in the periphery. I want it right around the catheter where it's going through the skin. So there are some hospitals that have switched from one chlorhexidine containing dressing to another, and they've even switched back to a different chlorhexidine containing dressing. But if hospitals are experiencing an increase in CLABSI, it's unreasonable to believe that switching from one chlorhexidine dressing to another will solve the problem. My suggestion is this, that the inserter and the RN go to the foot of the bed and take a look at the central venous catheter. And then ask the question, is that insertion, is it optimal, is it acceptable, or is it suboptimal? And another one is, would I want this for my patients or my family? And basically, all of your products are going to work better if the line is inserted properly. So what constitutes a proper insertion? Number one, minimal attempts, hopefully one. Number two, the tip should be down near the cavoatrial junction. A proper exit site, no hubbing. I don't use sutures for 15 years. Antimicrobial protection, and we want the dressing to stay intact for 7 days without disruption and without adhesive tape. So what is the goal in all this? I say I'm trying to standardize practice at the highest level because we work on human beings. So you hear about this all the time. What's the big deal? What do you get out of standardizing practice? It can eliminate unnecessary variation. And what do you think unnecessary variation does to your outcomes? My framework for dealing with this I call the life cycle of a central venous catheter, with the goal of standardizing practice at each phase of the life cycle. The life cycle consists of first phase is assessment, pre-insertion, what you know is the insertion bundle, followed by the actual insertion of the device, the dressing care and maintenance, and the removal. Anything bad or anything good happens in one or more of these phases because that's all there is, and that's all there'll ever be. Another way to look at this is the chain of CLABSI prevention. So basically, there are 5 phases in my framework. These 4 account for 1% of the life of the line, and the dressing, care, and maintenance phase accounts for 99%. So if you were going to affect your infection rate, would you deal with the little orange sliver or the big blue pie? The action's clearly in the big blue pie, but it's related to the way we insert these things, right? So what happens after a central venous catheter is inserted? It is given to an RN to use and to manage. Central venous catheters are nursing tools. So before we start, nurse, I could put this catheter in his neck or in his chest. Where do you prefer to care for it? The catheter exits from the chest or exits from the neck?
From the chest.
Why?
Because it's easier. Usually the dressing will lie flat.
Thank you. So basically, it comes down to this. Anything near the ear is bad, and anything down near the chest is good in terms of preventing a dressing disruption and preventing infection, right? So certainly I can't go through the whole life cycle, but we're going to move into phase 3, the actual insertion of the device. So during this phase, I say there are 16 decisions, their choices, and my recommendations. And these are the 16. And certainly we can't cover 16. Decision number 1 is to use ultrasound always. Number 2, where are we going to place these central venous catheters?
No, 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 no. I said no, no. You're not the one for me.
So you're hearing the audio, yes? Joe? Okay. All right. So
Yes,
what is my objection to the internal jugular vein? Like, what's the problem with the internal jugular? I mean, it's the most popular site on the planet. Basically, there are too many ways to insert it poorly. It's not inserted in standardized fashion, right? You could put it high in the neck, you could put it in the middle of the neck, and you could put it low in the neck. I usually ask vascular access experts, where do you want the exit site? And the people I talk to tell me they want it low in the neck, right? So anything else is not standardized at the highest level. My principle number 1 is low in the neck, and I consider this to be mandatory. So I want to talk about the catheter dressing as a unit. The catheter has to exit from the dressing, otherwise the nurse can't use it, right? So here's a typical IJ insertion, and basically the catheter can exit from the dressing north or south, east or west. So let's say the catheter exits from the east side of the dressing. You might get a configuration like this. And somebody that went to medical school put the dressing on the patient's mouth. And I'm sorry, I don't really know what to say about it, but you can't go to the library and look this up, but it's not good for the patient. You can have the catheter exit from the west side of the dressing, and you might get a configuration like this. The classic is the doctor goes to the head of the bed and directs the catheter northward, and you might get a configuration like this where there's adhesive tape all over the place. Or you can have the catheter exit from the south side of the dressing, and it'll look something like this. So what is the goal again? Standardizing practice at the highest level to eliminate unnecessary variation. Which configuration standardizes practice at the highest level? It's the one where the catheter is exiting from the south side of the dressing. Anything else is not standardized at the highest level. Another thing is, the catheter does not kink. Principle number 1 was low in the neck. Principle number 2, rotate the catheter downward, right? This is what I'm talking about.
Fold this thing down toward the chest, not up near the ear. Okay, I do not want this dressing up near the middle of the neck. I want it down toward the chest where it belongs. All right, so we're going to put the on with the slit facing the catheter, and we're going to offset it of just a small amount, maybe about 10 degrees. Right, the catheter. All right, we're going to do the skin prep. Okay, so we're going to take off the rest of it. Okay. Thank you, man.
Does that dressing look like it'll stay on for 7 days? Does it look like it's preventing infection? And to me, it does. Has anybody ever seen a catheter put into the hub? The nurses don't like it. They can't come by and clean it. That picture on the lower right was furnished to me by your infection preventionist, where the catheter is put into the hub. That secondary site, I won't discuss today, but it shouldn't be used in this patient. And then there's no room for the chlorhexidine disc, so they just throw it on top. So to prevent hubbing is simple. Don't hub the catheter. It's a simple concept. You don't have to hub the catheter, right? And this is what I'm talking about.
This is a 20 centimeter catheter is 21.5 centimeters in length.
you can see that the company has engineered this so that I have room to put a proper dressing. I do not have to stick this into the hub, but I've got 1.5 centimeters in order to put a proper dressing on this thing without sticking the catheter into the hub, which I don't. All right, so I have my stop on. Does that dressing look like it'll stay intact for 7 days? All right, in my lecture, I usually cover 5 procedures. Today, I'm going to cover 1 or 2 procedures. We're going to talk about percutaneous internal jugular vein insertion, right? So basically, principle number 1, we want it low in the neck. So I come from the side of the bed, low in the neck, and I rotate it down.
We're going to puncture the vein as low down above the clavicle as we can.
Because the dressing is vital. To prevent infection, an intact dressing is vital. That's an in-plane puncture. There's my needle coming down through the carotid sheath into the jugular vein. We use micropuncture equipment always.
Now the wire's good. Now the wire. See that? We're nice and low in the neck. We're not in the middle. We're going to put the 5 French micro introducer over the 0.18 inch wire. Okay.
We don't cut the skin.
We're not going to cut the skin, because the skin is the barrier to infection. This feels like it's going to move. The inner cannula and the wire. We're going to put a finger over the hole from the set. We're going to put this in to about 18. Now we're going to dilate with the 7 French dilator. Okay, it's going to feel a little bit of pushing now. Just go in. Okay, so go in and rest. Okay, there. That we're going to put in the 7 French triple lumen catheter. Going in smoothly. We're going to put this into about 19 to 20 centimeters. Because the nursing step, nurse, where would you rather care for this catheter, in the neck or in the chest?
Chest.
Low in the neck, rotate it down so the dressing stays intact. I'm going to make, all right, the next procedure I'm going to talk about is the acute hemodialysis. I'm going to make a prediction. The catheter with the worst infection record at Inova is the acute hemodialysis catheters. Why do I say that? Every hospital I go to, that's the catheter with the worst record. Here's a procedure. I'm going to put an acute hemodialysis catheter. I'm working with a resident. He's doing some, I'm doing some. We're coming from the side of the bed, low in the neck, rotating it downward. We're going to use a dressing adhesive. We're not going to cut the skin.
Look at the probe. Hit the center of the probe, Christopher. Hit the center of the probe. I'll tell you when to look at the screen. You look at the probe.
There's my needle in the jugular vein.
Pinch
Patient
it.
has a short neck and a beard, an endotracheal tube.
Slowly.
I do not want a dressing by his mandible or his ear.
Okay. We're going to sink that.
Micropuncture equipment.
I do not want to cut the skin of this man with an INR of 3.9. 4. Okay, now because it's been dilated once, we should be able to get this appropriate. You put a little traction on the wire. Okay. Okay. Okay, that's 20, I think. So teaching point is, in a patient like this with a short neck, on a ventilator with an endotracheal tube, we do not want a dressing up near the mandible, the hairline, or the ear. We want it down on the chest. Nurse, where do you want the dressing this patient, on the neck or on the chest?
Chest.
Why? Because it lies better and you can provide proper care and maintenance?
Yeah.
Did I put words in your mouth?
Yep.
Okay. All right. And the dressing is going to have a good chance to stay on for the 7 days. Good.
Sorry, you're okay, sir.
You're okay.
It's almost over.
Relax. You're all right.
Okay, and I can feel the dressing going on. Very nice, very in sticky position. So we're going to retract all this. Good.
Is that what HD catheters look like at Inova? And if not, why not? It's 2025. There have been a lot of advances. That's what they're supposed to look like. I'm going to summarize this thing. Proper care and maintenance is 99% of the life of the catheter. It depends on a proper insertion. And that means the dressing's not by the mandible and not by the ear. Before changing from one chlorhexidine dressing to another one, I want you to fix insertion practices first. These are my recommendations. fix insertion first. The exit site, the securement, the dressing, they're a unit. They haven't, like the stuff they teach us about washing our hands and prepping the skin and draping the patient, they're important and they help prevent infection during the procedure. These things are permanent. They help you prevent infection throughout the life of the line. I take photos and videos. That's how I can tell if a line is inserted properly, right? Care and maintenance is 99%. It depends on the way we put in the line. Thank you for your attention.
Thank you for all of that. Before I open it for questions, I just want to, because you talked about the sutureless securement, I just want to make it clear to everybody. I'm assuming it's a policy that we suture these down. That is not something that we are advocating for in this discussion right now. So that everybody's clear. Okay. Does anyone have questions?
Hey Joe, I'm sorry. Did you say we're not suturing them anymore?
No, I said I'm not advocating. I know. Jack mentioned that, but we are not. I'm not saying that.
I guess tell us about that. Like, why don't you suture lines in? Do you feel like they move in and out, or you feel like it's just unnecessary and they don't fall out on their own?
So, okay. So number one is I try not to violate the skin, which is the natural barrier to infection, with sutures or incisions as much as possible. I don't know if there are any societies that recommend suturing. Certainly the CDC and the INS, the Infusion Nursing Society, recommend against suturing for a number of reasons. Needle stick injury, violating the skin, increased risk of infection. I haven't sutured myself in 17 years, but it's dependent on putting in the line properly. If you've got something up by the ear sticking out, you've got to put the line in properly. But I would say you're probably behind the times if you're still suturing. And we could discuss that further, but there's not a lot more people that don't use. There are different types of sutureless securement. The adhesive one, you have to change the adhesive one with each dressing change, whether they do that or not. There's a cool subcutaneous device that I didn't have time to show that's permanent, that holds the line in place. But once you give up suturing and start doing this, you won't go back to it. It's,
Yes, I mean, Chris, maybe it's something we need to look into.
Sure.
Other
What about
questions?
A-lines?
A-line's the same.
A-lines.
Yeah, A-line's the same. I don't suture A-lines. They have securement devices, usually adhesive. I don't know if they have the subcutaneous securement. Yeah, I don't suture A-lines.
I don't know if I think I could get on board if it was somebody who's like sedated, intubated. But if it's somebody like walking or like that's truly mobile in a unit, I think I'd have a little bit of fear that an A-line might get yanked pretty easy. I think a central, maybe I could get
And central lines will get tugged if like all the tubing connected to them isn't secured.
Yeah.
I think they'll get tugged.
So
maybe we could.
Even when sutured.
So the doctor brought up fear. Fear is kind of irrational, but that's the kind of thing that we have to get over to move ahead with certain advances. But I respect, if you haven't done these things, then your fear is warranted. But, as I say, I've done this for over a decade, and I know they work. I mean, there's no evidence that sutures hold better than any of the engineered securement devices. There is no evidence on that.
That's a fair statement. I think if we change it, I'd want to do it first in maybe our patients who are a little less mobile initially, and then as we kind of see how we do, then extend it out. I don't know. I'm interested in what
I
is
feel
think.
like trialing the securement devices would be helpful too, because if we don't have securement devices, it's...
So your PIC nurses have them. Your PIC nurses don't suture. So
Yes, they do.
They suture?
No,
No.
you're absolutely right. They have those. We put them in for the PICs, the little suture device.
Yeah.
Yeah. That little big, it's like a thick purple one that they clip over. Yeah.
All right, Hussein, do you have your hand up? Last comment, and then I want to move on to SedLine.
I've been in both the hospital systems I worked in. We've used these stat locks, and they work 99% of the time. But the sweaty patient, they just come right off. I know there's ways to get around that, but some patients are just so febrile and sweaty and hairy and all of that it gets really challenging. And when we trialed it at Nova, we'd done away with it because of that in the past. We've tried this before, and I agree with the speaker that if you once you get used to these, they are fun to use, but it's cumbersome to learn. People are afraid to put them. But the truth is, you can't do it on every single patient, especially with our demographics. We have patients who have incredibly hairy skin and are very sweaty when they're febrile and septic. So they're supposed to work, but maybe I can be retaught to make it work in those situations.
All right. Thanks a lot.
Yeah, thank you. I appreciate it.
You're welcome.
I think we'll have to have some offline discussions about potentially triangling it again and looking at back what was tried in the past. It sounds like
so. Consider bringing me in for like a grand rounds or a full lecture, and we can discuss some of those things. So anyway, thank you for your time. I really appreciate it. Yep.
Okay, Rory, I think I saw you on Rory Mullen. He's going to be talking a little bit about SedLine.